Hello everyone, I'm Mark Dugay, a graduate student of Grand Canyon University. In this presentation, I'll be explaining an aspect of respiratory physiology, particularly in the function of pulmonary surfactant. Starting with this figure, the composition and function of surfactant. Surfactant is composed of 90% lipid and 10% protein. Its components are synthesized primarily by the alveolar type II cell and the airway club cell, which produce surfactant lipids and surfactant proteins. The lipid content contains primarily phospholipid, of which the most abundant species are dipalmitoyl phosphatidylcholine, or the DDPC, and unsaturated phosphatidylcholine, which is responsible for the biophysical function of surfactant, increases the surfactant's fluidity so it can absorb oxygen more efficiently. Surfactant also contains four associated proteins, two hydrophilic surfactant proteins, or the SPA, and SPD, where they play an important role in host defense and immune modulation, whereas surfactant protein B and surfactant protein C are hydrophobic proteins, primarily partake in modulating biophysical properties. Surfactant proteins enhance chemotaxis and phagocytosis. They inhibit the growth of pathogens and aggregation and opsonization of microorganisms. So this is a process or molecular mechanism that uses opsonins, which are antibody molecules such as the IgM that are capable of activating the complement system to increase the susceptibility of antigens to phagocytosis. Surfactant protein B is an indispensable protein that plays a role in enhancing the surface tension reducing properties of surfactant and also appears to have some antimicrobial activity. Figure 2 shows the surfactant life cycle, the synthesis, secretion, and recycling. Surfactant is produced by the alveolar type II cells utilizing dietary substrates. These specific pneumocytes line the alveolar compartment of the lungs, which cover about 7% of alveolar epithelial surface. Surfactant is synthesized in the endoplasmic reticulum of alveolar type II cells and transported to the Golgi apparatus for further modification. Most of the surfactant components are stored in the lamellar bodies until they are secreted into liquid hypophase on the alveoli by exocytosis. Surfactant forms tubular myelin, a lattice-like structure that is lung-specific and produced in the alveolar airspace. The tubular myelin is transported to the air-liquid interface to form a monolayer of surfactant film. These phospholipids are either internalized and degraded by macrophages or recycled by the type II cells for reuse. The surfactant protein SPA, SPB, and SPD are also synthesized in club cells in terminal bronchioles. So this is the surfactant life cycle. This figure presents the role of pulmonary surfactant in counteracting the tendency for small alveoli to collapse into larger alveoli. According to the law of Laplace, which states that the magnitude of the inward directed collapsing pressure is directly proportional to the surface tension and inversely proportional to the radius of the bubble. So without pulmonary surfactant, if two alveoli of unequal size but the same surface tension are connected by the same terminal airway, the smaller alveolus has a tendency to collapse and empty its air into the larger of alveolus because it generates larger inward directed collapsing pressure. Whereas with pulmonary surfactant, it reduces the surface tension of a smaller alveolus more than that of a larger alveolus. This reduction in surface tension offsets the effect of the smaller radius in determining the inward directed pressure. Consequently, the collapsing pressures of the small and large alveoli are comparable. Therefore, in the presence of pulmonary surfactant, a small alveolus does not collapse and empty its air into the larger alveolus. So if the surface tension increases, the inward directed collapsing pressure also increases. Same happens if one of these decreases because these are directly related to each other. Whereas if radius of bubble increases, the inward directed collapsing pressure also decreases, or the other way around because these are inversely related to each other. This scholarly article titled Effect of Recombinant Surfactant Protein C-based Surfactant on the Acute Respiratory Distress Syndrome is related to the assignment presented. The Acute Respiratory Distress Syndrome, or ARDS, or commonly known as wet lung, is a condition in which fluid collects in the air sacs of the lungs where oxygen is deprived. In this study, the effects of recombinant surfactant protein C-based surfactant on the acute respiratory distress syndrome was evaluated. Table 1 presents the baseline demographic and physiological characteristics. Patients from North America, Europe, and South Africa were randomly assigned to receive either standard therapy for acute respiratory distress syndrome or ARDS as the control group, or standard therapy plus the recombinant surfactant protein C-based surfactant or the exogenous surfactant as the experimental group. This study involved 448 combination of male and female patients with ARDS, 224 patients for each group as shown in the pooled data. These groups were similar at baseline with respect to sex, age, scores on the acute physiology and chronic health evaluation, and vital signs, arterial blood gas measurements, ventilatory variables, and sequential organ failure assessment scores. Table 2 shows the factors predisposing patients to acute respiratory distress syndrome. The most frequent predisposing event to ARDS was sepsis, followed by pneumonia and trauma or surgery. For the other events category, the most common diagnoses were drug overdose, liver failure, pulmonary fat metabolism, influenza, and septic shock. Table 3 shows the outcome measures. After the treatment for 28 days, there was no significant difference between the groups in the distribution or median number of ventilator-free days per patient. The survival rate at 28 days also not differ significantly between the groups. The average survival rate 28 days after the treatment was 60%. Or 66% rather. There was no significant difference between the groups in terms of mortality or the need for mechanical ventilation. Figure 1 shows the mean partial pressure of oxygen and fraction of oxygen in the inspired gas, values in the control group and the surfactant group. The partial pressure of oxygen and fraction of oxygen in inspired gas is measured of the blood oxygenating ability of the lung. As shown in the figure, the mean partial pressure of oxygen and fraction of oxygen in inspired gas value was significantly greater from 4 to 24 hours after the treatment in the surfactant group than in the control group. Figure 2 shows the number of ventilator-free days in the control group and the surfactant group. Patients with 0 ventilator-free days included those who were never free from mechanical ventilation and those who died within 28 days after treatment, regardless of their need for mechanical ventilation. As the figure shows, there were no significant difference between the two groups. Figure 3 shows the non-pulmonary organ failure during the 28 days after treatment among patients with ARDS as a result of direct or indirect lung injury. Direct ARDS was defined as ARDS due to pneumonia, aspiration, or both. The number of non-pulmonary organs that failed, with failure of an organ defined as source of 3 or 4 sequential organ failure assessment, was significantly greater among patients with indirect ARDS than among those with direct ARDS. The interaction between the treatment and the cause of ARDS, direct or indirect, was significant for the mortality analysis and did not reach significance for the analysis of the number of ventilator-free days, indicating that among patients with ARDS caused by indirect lung injury, those who received surfactant tended to have a higher survival rate than those who received standard therapy. Based on the results of the study, the researchers concluded that the patients who received the recombinant surfactant protein C-based surfactant had a remarkable improvement in blood oxygenation during the 24-hour treatment period compared to those who received standard therapy alone. However, the use of this exogenous surfactant to patients with ARDS did not improve survival. Okay, so these are my references. Mahalo.